Always nice to see another veteran up here. That was an absolutely outstanding presentation. So I am tasked to chat with you about the value of the neurosurgeon a lot. Thank you for giving me this opportunity to have this conversation with our colleagues. And Garni, what a scientific program you and your committee have put together. So the value of the neurosurgeon, difficult topic to try and encompass. So I had never read this book from cover to cover until my wife had a harebrained idea to homeschool our kids during the pandemic. And you can only get books that are out of copyright. So this is what I'm trying to read to my 13-year-old who's going nuts because he doesn't get to leave the house. But the genius of this book, as it turns out, is that looking at the past, present, and future simultaneously gives you a framework. And the tragic hero of this book changes his trajectory by seeing those all at once. So let's try that for the value of the neurosurgeon. Let's take a look at the present. This is something that so many in the audience are dealing with every day. 55-year-old man comes in, worst headache of his life, declines to the point that he needs intubation, gets transferred to a center of excellence in vascular neurosurgery, and is found to have a pica aneurysm, ends up with an endovascular procedure that obliterates the aneurysm, and then makes a remarkable recovery. This is a father of 3 who has a meaningful employment. He has a wife. He's a member of his society. And this is what everyone in the audience is contributing to day in and day out. And then he's followed over time. Maybe there's something coming on at the 3-month, and certainly at the 6-month, there is a recurrent aneurysm. And that is managed, again, by the same neurosurgeon with a definitive clip ligation of the aneurysm. What is the value to this patient, to their family, to the wife, to the children? That is managed by our president, Dr. Elad Levy. What about this young man? 18-year-old kid, takes a header off of a dock, ends up with an incomplete spinal cord injury, not moving his legs. He's got function slightly below the level of the injury. A neurosurgeon is on call. Responds to that call, comes in, does a corpectomy, decompresses the spinal cord, flips him over, decompresses the lamina. Now the spinal cord can swell, and this young man has a second chance. He makes a remarkable recovery from full paraplegia, walks out of the hospital with weakness in his non-dominant hand. That's taken care of by our treasurer, Dan Ho. And finally, a man who comes in, 19-year-old man with headaches, up-gaze palsy, cerebral spinal fluid, does not give us the characteristics of this lesion, ends up having a gross total resection, adjuvant chemotherapy and radiation. This is taken care of by Dr. Lola Chambers. Tell me the value of neurosurgery. How do we quantify that? Now, there are actuaries that can actually try and put something on there, and they would say, yeah, hey, look, you got a 19-year-old kid who's tetraplegic, that's going to cost $5.8 million. Do we really think that that encompasses all of the elements of what that injury is causing to that individual? Because the reality is the value of the neurosurgeon in each one of these settings is without measure. And these are the cases that everyone in the audience is managing, so we can multiply it by that year after year. But $5.8 million doesn't cover it, because what does John Steinbeck say? If anything that just costs money is only cheap. Having looked at the present, where we are now, let's take a look at the past. Let's look at the decisions that were made very early. Sanford Larson, Volker Sonntag, and I think you recognize that gentleman on the last slide. Dr. Nelson Hopkins. So Sanford Larson, very early, made a decision. Neurosurgeons are not going to be stopped at the dura. We are not going to be stopped doing decompressions, laminectomies, the occasional spinal cord tumor. He made a very intentional decision saying, we are going to instrument the spine. We are going to be the definitive surgeons from A to Z, and he had a disciple in that. Volker Sonntag arrived in Phoenix, was already instrumenting the spine to take care of the unique traumas that he encountered. And together they trained resident after resident, fellow after fellow, and now instrumentation of the spine is something that not that we take it for granted, but it's something that we don't even notice if it wasn't even, it's part of our training. And then Nelson Hopkins, we saw that. I was unaware of all of the no's that he had every single step of the way. No, you can't use our equipment. No, you can't use a catheter. No, you can't do this, you can't do that. And that was the pathway. These are the decisions that were made very early in at an inflection point in neurosurgery that now landed us where Elad Levy is doing these procedures that you saw that started off this talk, and Dan Ho is doing the instrumentation. Now that we've looked at the present and the past, let's take a look at the future. The future in neurosurgery looks very bright. Here we have Dan Barrow and Gustavo Prodigia's study on ENRICH. And the spine guys welcome the fact that our intracranial colleagues are now beginning to use the tubes that we've been using since 1997. But the impact that this has on the outcomes for these patients who have intraparenchymal hemorrhages that we used to watch or hem and haw now can improve their outcome. This is going to increase the value to our patients and increase the value of neurosurgery. And this has been covered already to great extent. The ability to make an impact. Residents now won't know what it's not to be able to do a mechanical thrombectomy. So much so that Bill Caldwell in a podcast, I reached out to Bill, make sure that he's in agreement with this. He thinks every neurosurgery resident moving forward, when they leave residency training, much in the same way we can fix a shunt, everyone should be able to do mechanical thrombectomy. That will cause a seismic shift in the ability to take care of the underrepresented. So now let's do a thought experiment. Take a look at this trajectory. Now this is just a hypothetical. This is, say in 2006, 5% of residents were going into functional neurosurgery. Just make that thought experiment, and in 2038, 85% are doing it. You would say, Lou, first of all, that's ridiculous. I'd go, bear with me, it's a thought experiment. You would say, you'd have to ask two questions. Number one, why are they going in that direction? Number two, how is that impacting cranial and spine? Because it can't be, that's an unbalance, that it would be untenable. And you say, okay, Lou, go to the next slide, that's never gonna happen. Let's just change the figure legends. This is what is happening with our hospital employed. And again, this is not a criticism of hospital employment, it's a criticism to the imbalance that is happening. What is driving this? This is the ghost of neurosurgery future. Now we have to ask the question. So another book I read during my foray as an English language art instructor during the pandemic, that was a disaster. I've never read this, but it's out of copyright, so I could read it. Alice goes into Wonderland after she goes down the proverbial rabbit hole, and she says, will you please tell me, to the Cheshire Cat, what direction I should go? And the Cheshire Cat says, well, it all depends on where it is that you do want to go. So, well, that's just it. I don't know which way I want to go. Then the Cheshire Cat says, then it really doesn't matter. Here is our metaphoric neurosurgeon standing before the Cheshire Cat, and we have to answer the question that the Cheshire Cat is asking. Which way do we want to go? Because if it really doesn't matter, here is where we're going to end up. And if this is okay, that's fine. But if we're going to alter this, then we're going to need a strategy. We do need to recognize that there are generational shifts, and the AMA has served this. This is not neurosurgeons, this is all of medicine. 70% of physicians under the age of 40 are now employed. But again, if we want to alter that, neurosurgeons play to win, right? And so if we're going to alter that, we need a strategy. We have a lot of tactics. We have the tactics of our rapid response committee, our powerful sections, we have the Washington committee, but what is our strategy? What are we teaching our residents to do when it comes to leaving residency and transitioning to the world? Are they prepared for what is out there? So how do we maintain the value of the neurosurgeon? In 2023, there are no problems, I would suggest, with neurosurgery as far as our advocacy efforts. We look at this meeting, look at the science being exchanged, look at the ideas being exchanged. Today is not the problem, but what will happen tomorrow if we continue down this path? Mark Linsky, I see Mark in the corner there. Mark, I still have your slide from your chairman's talk. Will employed or salaried neurosurgeons have the same characteristics that we have today? If it's 85% hospital employed, again, it's more the imbalance than the subtype. Will salaried employment lead to a herd passivity, complacency, a sense of impotence and corporate futility as opposed to the interdependence, outspokenness, and leadership? Again, is this an issue? Is this not? These are the questions that we have to answer. Take you to the beaches of Hawaii where Steve Jobs is entertaining the notion of going back to Apple, and he says, you know, I'm thinking I'm not going to take any stock options and I'm not going to take any pay because I'll have the moral high ground. And Larry Ellison says, whoa, this moral high ground that you're talking about, Steve, that's very expensive real estate. How many times have we been in that moral high ground too? Hey, we just take care of patients, everything else is going to take care of itself. You know what? It's how you keep score. Larry Ellison says to Steve, he goes, well, why shouldn't we be the ones to get it? Why should it go to the fund manager? We're taking all the risks. We're coming up with the idea. We're coordinating and driving these companies. It should be us that benefit. I say the same thing. It is you who put the patient under anesthesia, you who take the risk, you who get up at 3 o'clock in the morning. It's not these guys. The administrators who are 3,200% increase since I started medical school in 1995. It's how you keep score, tells us Jobs. How about this scoreboard? These curves look pretty good. Let's take a look at the neurosurgery scoreboard. Ours is in blue, 6 cuts since 1998. Orange is what it looked like if, in fact, it kept up with inflation. So what are we going to do about that shortfall? There's several things that we can do, and we have to ask ourselves if we want to do them as an organization, because I prefer that other curve. But here, this is a reality. 3 letters. This is something that neurosurgery has been flat-footed on that our other specialties have not. If you look at orthopedics, if you look at ENT, they have a systematic entrance into ASCs. They teach this. The arguments against the ASC with residency training are ill-founded, that it's detrimental to the residency training. It's essential to the residency training. That it's divisive between cranial and spinal. I had to pull out all the slides with all the papers that from our Canadian colleagues and from my partner, Nader Sinai, who's done 107 outpatient biopsies, because I ran out of time. But an ASC for a neurosurgeon is something that we need to be very definitive. Hospital-employed, academic, and private practice should all be benefiting from this. Remember, when they say no, that's when Nelson Hopkins takes action. That's when we should take action too. We're more worried about our residents knowing the fields of Farrell than they are about co-management agreements. And if they know the interstitial nucleus of Ramon and Cajal, they should know about gain sharing too. And there is no one in this room, I believe, it is my personal belief, who is taking trauma call, taking stroke call, who is not receiving a stipend. This is what's going to make up for that shortfall. It's how you keep score. This is our action plan if we choose to take it. We have a society of university neurosurgeons. What about the society of employed neurosurgeons? Because there's a lot of you out there in the audience who are just going, look, Lou, you've got us all wrong. I've got a very good deal. I know you have a good deal. There's a lot of employed neurosurgeons out there who have cracked the code. But there's a lot of vulnerable neurosurgeons who are going into employed agreements who have not. We need to have a coordinated assault on this issue. We need to also create an environment that's going to foster and empower private practice for the years and decades to come, or we're going to end up in a trajectory. Again, it's not the criticism of the practice type. I think we can all agree we need to do something about the imbalance. Again, it's looking at the past, present, and future simultaneously, looking at what Volker Sonntag did, Sanford Larson did, and what Nelson Hopkins did to change the trajectory of where we are to have what we have today. We can also do that. And there you have it. The value of the neurosurgeon, a la Charles Dickens. We all have to recognize that if it only costs money, it's cheap. We have a Cheshire Cat moment that we've got to answer, and no presentation is complete without the Art of War quote. What is our strategy so that we can put our tactics into place? Remember, it's how you can keep score. Because I think we can all agree, the value of the neurosurgeon to these patients, to all the patients that you take care of, is without measure. Let's go do something about it. Thank you.